Dignitas International is a medical and research organization that was founded in 2004. The organization was really created as a way of addressing the humanitarian emergency of the HIV epidemic in sub-Saharan Africa. It was founded with the idea that delivering services and providing medical care would be linked hand in hand with doing research and evaluation. Questions could be generated from programs that were being delivered to inform the research, and that the research could feed back to improve programs, but also feed back to policymakers so that they can learn from the lessons generated by delivery of services and research to take good ideas and bring them to scale, and also put ideas that don't work to rest. Because the most important piece of global health research is probably actually delivering health, we were really focused in the first 2 to 3 years of our work on just trying to get a program up and running. We established Tisangani Clinic. We took the lessons from that clinic and decentralized it to all of the rural primary health centers in the district that we were in. That was then taken to several districts so that we were finally covering the area that we're supporting, which is a quarter of Malawi in the southeast zone population of 3.1 million people. From 2008 to 2010, it was really about moving from doing operational audits to doing real research. So that included building a database in order to try to capture the outcomes in the district through an observational cohort study. It also included bringing on our first clinical study to look at opportunistic infections that affect HIV-positive patients who are profoundly immunocompromised. It also meant looking at operations research to evaluate some of the innovative programming that we were coming out with to address the HIV crisis, including our healthcare worker clinic, our TB/HIV integration clinic, and also our expert patients program, which takes HIV positive patients and it engages them to help mitigate the human resources for health crisis, shifting tasks from nurses to some of these patients to help in the clinic. It was also a time where we started to engage with researchers from outside of Malawi, including a group of South African researchers who had a real interest in looking at tools that could enhance the ability of nurses and medical assistants to deliver primary care. During that time, we had funding to conduct our first cluster randomized control trial looking at the impact of one of these guidelines and tools in improving primary health services delivery. 2010 was a real marker year for us because that was the year that the WHO started to roll out a policy that we know as Option B, and that was basically recommending that all HIV-positive women who were pregnant get offered antiretroviral therapy over the course of their pregnancy. Now, Malawi took that opportunity to adopt a new program that went beyond the WHO recommendations called B+. And this was partly informed by evidence that had been generated by our organization showing the old way, which was a single drug given at the time of delivery, that the rates of HIV transmission were just as bad as if we did nothing. And so the Malawi government really took that as an opportunity that we really needed to do more for these women, and so recommended that all HIV positive pregnant women basically get started on treatment for life. This was a really novel opportunity internationally because it was the first time treatment as prevention approach or a universal test and treat approach was adopted at a population level in a high prevalence, low resource setting. For the country, it was a real opportunity to lead the charge, and from a research perspective, to look at what are the ways that we could optimize treatment as prevention. We took it as an opportunity to evaluate what are the questions that need to be answered, how can we divide up the work, how can we work together to optimize resources that are coming in so that it's done efficiently and in a way where we're going to get rapid results quickly that can impact programming. Moving forward from 2010, there were 2 new directions that we were moving in. In addition to trying to publish a lot of the work around our programming and some of the operations research we were doing, we were also expanding our competencies by bringing on researchers who had an interest in social science and anthropology as well, so that we could further explore barriers and facilitators to accessing care, and also try to figure out ways of engaging some of the key populations that are marginalized for a variety of reasons and may not access some of the care that we were providing. In addition, the other big piece was the development of clinical research capacity. First study that we were engaged with was a study called Cryptidex. This study was basically looking at whether or not steroids could improve the outcomes of patients with cryptococcal meningitis who were treated with antifungals. Cryptococcal meningitis being a fungal meningitis that HIV-positive patients who are profoundly immunocompromised get. Why was this study important? Well, I think it was important because it allowed us to access medications that I think otherwise were not readily available in Malawi, but that were on the formulary. It also allowed us to bring in some enhanced research capacity and do some capacity building, and also improve clinical care for patients who have cryptococcal meningitis. Finally, it was important because it really was a test for us to see whether or not we could potentially be a clinical trial site and add that to the component of work that we do. In the last year, we've managed to bring on 3 additional clinical trials to look at very important questions that are relevant to African HIV patients in terms of improving their clinical care that could potentially have huge impacts on international guidelines as well as practice in settings like where we work. There really is a disconnect between policymakers and researchers, that often policymakers don't understand research and aren't communicating enough with research, don't know what sort of research is actually going on in their country, whereas researchers aren't sitting at the table to be able to give the results of their studies to policymakers. And so how do we bridge the gap between researchers and policymakers? We have actively sought out to adopt a knowledge translation strategy that includes building knowledge translation capacity within Malawi. We've partnered with WHO and the Malawi Ministry of Health to establish a knowledge translation platform that allows Ministry of Health people who are engaged in research and program delivery to bring together researchers around questions of importance for the government, and that's a huge piece of the work that we do. We've been approached and have engaged with the Sioux Lookout First Nations Health Authority to establish an Aboriginal Health Partners program, and are in the process of implementing a program to address the burden of non-communicable diseases using some of the community health worker strategies and task shifting strategies that we were using in Malawi around HIV. One of the best parts of working with Dignitas, and what I think really makes it a unique organization, is the fact that delivery of services for our patients and delivery of programs is so interlinked with generating evidence. It's not about just doing studies or doing research for the sake of doing research. It's really about it being a means to an end, the end being the ability to provide better care and also the ability to potentially improve equity of access for people that otherwise might not be able to receive or are marginalized from receiving services.